Yeah, as I said, I hope you can all see my screen. A warm welcome again to our fetal cardiac MRI session using our Doppler ultrasound gating device SmartSync. This is our second session for this year, our summer session. So as I said, this webinar will be recorded for your information. The recording will be online very soon. And today, your moderators are my dear colleague Domenico, our clinical application specialist, who is sitting right next to me, and myself, Leah.
Hi, everyone.
So this place or this webinar is always a place where we aim to connect people, where we want to establish an exchange, where we can learn from each other. So we're really having the aim to build a community here. So please feel free to join any discussions, ask questions. You can do that directly in the chat or use the Q&A function. You can also raise your hand if you would like to speak, and then we will allow you to use your microphone. So all questions are allowed. As I said, we are very happy if a discussion starts. And also another opportunity to connect is the International Fetal CMR group. This is a QR code that you can scan here, where you can then enter the official WhatsApp group. It's a group also, again, if you have any questions regarding upcoming conferences, publication, it doesn't matter if you're new to the field or if you're already an experienced user. I think it's always nice to have a community around where you can help each other. So if you're interested in that, just scan the QR code to join the group. So today's session, the summer session, has the topic from training to clinical practice, the successful implementation of fetal cardiac MRI. So we're really aiming here to get some insights really from clinics where we will see clinical cases, how fetal CMR has started, what has helped to really establish this program. Because of course we know, it's not just a device that we're bringing out to the world, but it's really an application. You have to learn about how to structure that and organize yourself. So I think it's a very relevant session here. Again, if any questions come up, we're happy to discuss them with you. And now I would really like to introduce our speakers for today. So I'm happy to introduce Paola Franceschi. She's a radiologist from University of Bologna. She will be our first speaker. Then we have Dr. Davide Curione, also radiologist in pediatric and cardiovascular imaging from Bambino Gesù Children's Hospital. Then Domenico will switch from moderator to speaker because he will also have a talk about our new training concept. So we will start with 3 Italian people, really strong here in that webinar. And then I'm also very happy to welcome Priya and also Philip from roclub, where we have just established a collaboration which will support your remote access, but they will talk about it later in detail. So Paola, you're very welcome to start sharing your slides now, and then you're off. You're off to go. That's what I wanted to say with your presentation. Yes.
Thank you. Okay. Can you see them properly?
Yes, we can.
Okay, perfect. Good afternoon, everyone, and thank you for the kind introduction and for the invitation. My name is Paola Franceschi, and I'm a radiologist from Bologna, Italy. Today, I'll share our experience in implementing fetal cardiac MRI in our clinical workflow. I will focus on the training pathway and the support that helped us start the program and continues to help us optimize it. I'll then show you some clinical cases from our experience so far. So how did everything start? Our institution purchased the North Medical SmartSync device in 2022, and I decided to focus my PhD project on fetal cardiovascular MRI. I was completely new to the field, so I connected with experience centers through the North Medical website. I spent 3 months at the University of Leeds with Dr. Malenka Bissell, and I also visited Dr. David Lloyd at King's College London. I also attended the Fetal Cardiac MRI workshop in the UK, which was extremely valuable. This allowed me to observe the real clinical workflows and learn many practical aspects. So if you're starting a fetal cardiac MRI program and you have the opportunity, my advice is to spend time in an experience center, because learning directly from experts can significantly accelerate the learning curve. Moving on to training, this was one of the most important steps. Of course, learning how to use the Doppler gating device is essential, but many other resources were also very helpful to me. For example, webinars, publications, online educational material that you can also find on North Medical website. Another key element was the remote support from the North Medical specialist, Domenico Gulla, who is also a speaker in this webinar. He provided remote assistance during scanning sessions, reviewed images afterwards, and helped us optimize sequences and exam cards for our specific scanner. Once we completed training, we started scanning in Bologna. We currently use a 3 Tesla scanner. The higher field strength provides excellent flow signal, although with more artifacts. We decided to work with a small dedicated team of radiographers so that they can build and maintain expertise on this very specialized and relatively low volume exam. One of the first things we learned is how important maternal comfort really is. When the mother is comfortable, the fetus tends to be calmer, and that results into better image quality. In our experience, many patients can lie comfortably in the supine position, which is generally our preferred option, especially at 3 Tesla. If the supine position isn't well tolerated, we usually switch to a left lateral tilt. We always place the Doppler probe before we start imaging, and then we position the anterior coil. It's very important to use pillows and supports to improve comfort and reduce the weight of the coil on the mother. We also need to be careful not to move or compress the Doppler device, because even a small tilt can affect the gating signal. Before the scan, we always take the time to explain the procedure clearly to the mother and let her know what to expect. Finally, once the anterior coil is in place, we check that the Doppler signal is stable on the sensor box before moving the patient into the scanner. Our workflow is based on a standard protocol that we adapt according to the clinical question. We usually start with localizers and T2-weighted images, which also help us confirm that the Doppler transducer is in the right position, as you can see in the images on the right. In our experience, if the transducer is placed correctly at the beginning of the exam, it rarely needs to be repositioned later on. Even when the fetus moves during the scan, it often goes back to its preferred position after a while. Of course, fetal motion is something we can avoid. When the fetus moves significantly, we usually try to acquire non-gated sequences. That said, sometimes it's actually better to just pause and wait, because even non-gated images can still be affected by motion. In terms of acquisition, we typically collect multiple T2-weighted stacks for slice-to-volume reconstruction. Then we acquire cine images in selected planes tailored to the specific clinical question. We also include 3D sequences for fetal weight estimation, and whenever possible, we acquire 2D and 4D flow sequences as well. One practical lesson we learned early on is to acquire the most important sequences as soon as possible. That way, we can secure the key diagnostic information before the fetus becomes more active. Now, moving on to the first clinical case. This case comes from our very first fetal cardiac MRI session in Bologna. It was a singleton pregnancy at 33 weeks and 4 days of gestation. Early fetal echo raised a suspicion of a right-sided PA-PVR and a possible scimitar syndrome. However, these findings couldn't be clearly confirmed on follow-up echo exams, so a fetal cardiac MRI was requested. Unfortunately, the mother became uncomfortable during the scan, and we had to stop the examination earlier than planned. Despite the limited acquisition, we were still able to obtain a few T2-weighted stacks that were sufficient to be processed using the North slice-to-volume reconstruction tool. On the right, you can see the original motion-affected T2-weighted images. Even in these images, if you look carefully, there is already a suspicion of PAPVR pointed by the arrows. However, our diagnostic confidence increased significantly after performing the SVR. Starting from motion-corrupted 2D images, the software generates a motion-corrected 3D volume that can be explored in any plane and that you can see at the bottom left of the slide. The latest version also includes automated segmentation and allows us to measure fetal lung volumes. In this particular case, the reconstruction made the PAPVR much easier to appreciate, and it also allowed us to quantify the hypoplasia of the right lung. So overall, in this patient, MRI clearly demonstrated the PAPVR, right lung hypoplasia, and the rightward mediastinal shift. There were, however, two structures that we couldn't clearly identify, the right pulmonary artery and the aortic arch. This was most likely due to their very small size, combined with the limited image quality from this incomplete study. Nevertheless, the examination still provided enough information to point toward a complex congenital heart disease and to support prenatal counseling as well as delivery planning at a tertiary referral center. And for us, this was quite a rewarding result, especially considering that it was our very first fetal cardiac MRI session in Bologna. Postnatal findings confirmed the diagnostic value of the exam, showing right-sided PAPVR, hypoplasia of the right lung and the pulmonary artery, and cortation of the aorta. As our experience grew, the image quality gradually improved. This second case shows a fetus with borderline hypoplastic left heart syndrome and hypoplasia of the aortic arch. MRI also identified an associated esophageal atresia with a tracheoesophageal fistula. This highlights another advantage of fetal MRI, that's the ability to assess not only the heart, but also extracardiac structures within the same examination. In this third case, fetal echo raised concern for chordae triatum associated with TAPVR, with a suspected drainage of the pulmonary veins into systemic veins. On MRI, however, we were able to demonstrate normal systemic and pulmonary venous connections. We also identified a left innominate vein with a subthymic course, but with normal drainage. As for the suspicion of chordae triatum, MRI does have some limitations compared to echo, especially when it comes to evaluating very thin intracardiac membranes, so we couldn't completely rule out the diagnosis. That said, we found no evidence of significant left atrial inflow obstruction and no flow turbulence that would suggest a hemodynamically relevant obstruction. This case also highlights another useful application. Using the NORTS post-processing platform, we were able to estimate fetal weight and index cardiac volumes. As we gain more experience and more cases, our image quality continued to improve. This case shows a vascular ring with the right aortic arch and the left ductus arteriosus, as you can clearly see on the T2 weighted images on the left and on the Cine white blood images on the right. We can really appreciate the vascular anatomy in detail, including the spatial relationship between the great vessels and the trachea. This final case shows a fetus with hypoplastic left heart syndrome, aortic atresia, and severe hypoplasia of the aortic arch with normal pulmonary venous drainage into the left atrium. I really hope that through these few examples, I've been able to show you how our image quality has gradually improved over time. Of course, there is still room for improvement, but we're quite satisfied with the progress we've made so far, especially considering that our experience is still relatively recent and that we chose what could be seen as a more challenging path by starting directly on a 3 Tesla scanner. I'd like to finish with a few practical take-home messages. One key point is that experience really matters. Image quality and success rates improve significantly with practice. Another important aspect is maternal comfort and communication. They're key to helping the mother feel relaxed, comfortable, and able to cooperate throughout the exam. It's also important to prioritize the most relevant sequences early in the exam. And when it comes to fetal motion, it's something that we should expect rather than fear. Sometimes repeating sequences is simply part of the protocol. And finally, patience is essential. It really becomes part of the protocol itself. So I thank you very much for your attention.
Great. Thank you very much, Paola. This was a really nice presentation. I think you could really nicely show, as you also stated, the journey from your first scans and then, yeah, being patient, but also continuing, of course, to scan and like improvement of the image quality. What you've also said, like you've visited the Hazelwood workshop, for example, what is like most, has like the most benefit for you, like meeting the people, talking to them, like how was your experience when like meeting the people there for the first time?
Yeah, I think the most valuable experience from the workshop was to be able to talk to people who struggle with the same problems you have. So you can ask them for advice, and obviously you can share your experience with them. So I think this is really helpful.
Yeah, amazing. Great. Yeah. Thank you for that. Of course, if we have more questions, then we will ask them or discuss them later. I would like now to hand over to our next speaker, Dr. Davide Curione. As I said, also radiologist from Bambino Gesù Children's Hospital in Rome. So you're very welcome to also share your slides now and begin with your presentation. Thank you.
Thank you. Can you see the slides?
Yes, we can.
Perfect. Okay. Good afternoon, everyone, and thank you for the introduction and for the invitation. I will also share our experience in implementing fetal cardiac MRI in clinical practice at our institution. I will first describe how we structured, how we built a structured clinical service, and then I will discuss some cases where fetal cardiac MRIs provided useful information complementary to echocardiography. I have nothing to disclose. So our journey began with some occasional attempts at fetal cardiac MRI in 2017, but we've only been able to perform exams consistently since 2021. And since 2024, we've had one dedicated session per month, performing up to 4 exams per session, with the collaboration of 2 radiologists, one specialized in cardiovascular and one in fetal imaging. To date, we've performed about 150 exams, which is still a relatively low volume, but it's helped us build a reproducible workflow and to gain some confidence in the technique. As we all know, one of the major challenges of fetal cardiac MRI is cardiac synchronization. Until 2022, we relied on real-time and metric optimized gating, which is a retrospective technique using a synthetic trigger that reconstructs CNA imaging by testing multiple heart rate patterns and selecting the one that produces the most coherent images. Since 2022, we've progressively switched to routinely using Doppler ultrasound gating. And since 2024, we've also had the chance to explore some self-gating research sequences, which we find useful so for some applications that we'll see later on. The problem with MOG and self-gating approaches is that although they can be easily implemented because they require no additional hardware, their routine clinical use is often impaired by the need for extensive offline post-processing before diagnostic images can actually be obtained. On the other hand, Doppler ultrasound requires a specific probe and can be subject to signal loss, but it allows simultaneous evaluation during the exam, which is one of its key advantages. In any case, we try to achieve a temporal resolution of about 50 milliseconds. Regarding our protocol, obviously we scan patients in the 3rd trimester where the fetal movements are less pronounced and where cardiovascular structures are big enough to be properly assessed. We used a 1.5 Tesla scanner and an 18 channel body coil. And this is the setup that we use to connect a Doppler ultrasound system to the Siemens scanner using a wireless connector box. We have both cardiac and non-cardiac sequences. Cardiac sequences are both static and dynamic. For static imaging, we use black blood haste sequences, although a little bit less frequently now because we find other sequences to be more useful. On the other hand, bright blood SSFP sequences remain the norm, although we switched to a modified version derived from research sequences, which I will show later. We always try to acquire dynamic images as well with CNS SFP images, which come in two different types, radial case-space sampling with 2 averages, which we used heavily in the past because it is not restricted. It does not have a field of view restriction and wraparound artifacts, but it can have signal issues and streak artifacts. And a standard Cartesian sampling sequence with a reduced field of view, which we've recently returned to after optimization. We try to routinely acquire flow measurements. Initially, we only did 2D phase contrast sequences, as shown in this example, but we've recently also introduced 4D flow, and we'll see some examples of this as well. We've also dabbled with mapping sequences, mainly for research purposes to calculate oxygen saturation using oximetry, but these are not currently part of our standard protocol. As mentioned earlier, we also introduced some research sequences of the various types available. We mainly use this one for its static images, which provide excellent image quality and are readily available at the scanner. Although by sending the raw data to a partner center in Switzerland, it is also possible to obtain a CNA version with in-plane and through-plane motion correction of these sequences, and we'll see some example later on. In addition, our exams also has some neuro and some standard neuro and body sequences. And for all sequences, we try to maintain a spatial resolution of about 1 to 1.5 millimeters in plane and a slice thickness of about 3 to 5 millimeters. And the overall duration of the exam is approximately 45 minutes. We currently don't have any established indication for a fetal cardiac MRI. We've tried to use it clinically to confirm or sometimes refine fetal echocardiography, mainly in congenital heart disease and to a lesser extent in cardiomyopathies and cardiac masses. And also it is useful, as Paola said, for associated extracardiac anomalies. All other applications, particularly studying fetal congenital heart disease, like for example for flow distribution or oxygen content and delivery, remain research oriented. After this background, let's move to some representative cases. This is one of our early vascular ring cases studied at 32 weeks of gestation. And this is an example of the CNA images that can be obtained by sending the raw data to our partner center in Switzerland. As you can see, it is... Okay, sorry. It is clearly demonstrated that there is vascular ring with a left posterior ductus arteriosus, a right aortic arch, and an aberrant left subclavian artery forming a vascular ring around the trachea and the esophagus. And there is one specific plane where you can see all the different components of the vascular ring. And this is what we currently do in our routine. We mainly use the research sequences for their static images in multiple planes. This is another case of a vascular ring, a similar vascular ring where echocardiography couldn't definitively determine the supraaortic vessel pattern, suspecting a mirror image branching pattern with a posterior left ductus. An MRI clearly demonstrates that there is a left posterior ductus, but the imaging pattern has a left subclavian artery that comes off from the left, and this could be an aberrant left subclavian artery or an isolated origin from the duct, but we couldn't confirm this differential diagnosis because this was a very recent case and the child hasn't been born yet. And then we obtained some CNA images, some standard CNA images, which also show the anatomy with the ductus and the right aortic arch. And in this case, we were even able to obtain a 3D reconstruction to show the overall anatomy better. Moving on to another case, this was a case of a double outlet right ventricle, and we can see both great vessel coming off the right ventricle with a discrepancy between the pulmonary artery, which is this, and the aorta, with a hypoplasia of the aorta extending through the arch, which is also visible in the coronal plane and is more evident. This is the aorta. We also obtained some CNA images with our earlier radial protocol, where you can see the vessels coming off from the right ventricle, the subpulmonary VSD, and the discrepancy between the great vessels. And also in the short axis view, we can confirm this findings and see that the ventricles are substantially balanced. This is an oblique view showing the vessels coming off the right ventricle. And given these anatomical findings, we decided to perform flow acquisitions and to quantify the flows. And as you can see, the pulmonary artery flow was about 3 times higher than the aortic flow, suggesting that there was a reduced antegrade systemic output and raising the concern for ductal dependence of the systemic circulation, which was already reported by echocardiography. This is another case of a suspected mild aortic orientation and mild ventricular discrepancy. As you can see in the different planes, there is there's only minimal discrepancy between the ductus and the aortic arch. And you can also see this in the other planes. Ventricular discrepancy was a little bit more evident, and in this case we even did quantification of the ventricles to show that there was the right ventricular volume was about 1.5 times that of the left ventricle, which was still of adequate size. And this is a demonstration of how fetal cardiac MRI can could provide quantification even in the fetal period. And to have a better definition of the discrepancy between the ducta and the aorta, we even did a 4D flow, which basically showed similar flow pattern between the two vessels, no flow acceleration, flow reversal, or preferential duct streaming through the ductus. This is the ductus and this is the arch. So further reducing the concern for aortic coarctation, which was ultimately ruled out after birth following ductal closure. And this is the last case of tetralogy of Fallot, where you can see the hypoplasia of the pulmonary arteries. Sorry, it's glitching maybe a bit. I see it glitching. Of the pulmonary arteries and the right ventricular outflow tract. And right ventricular, I'll try to it's not working properly, but anyway, there was a question with echocardiography. Echocardiography reported a dextropositioned aorta and could not rule out definitively a double outlet right ventricle. So we performed 4D flow in this case as well, and showed that the aortic flow was coming predominantly from the left ventricle through the subaortic ventricular septal defect, supporting the diagnosis of regular tetralogy of Fallot. And this is a case where flow imaging can sometimes help clarify anatomical ambiguities a little bit better. And this brings to the end of our presentation. Thank you very much for your attention.
Great. Thank you very much, Davide, for showing so many cases and also showing what has worked for you. Which indications, let's call it like that, you're looking at. Maybe one question time.
I think it's great to see, how the journey in fetal CMR started since 2017. And I have just one question. So it's more related to how did you structure and organize the teams internally? So if you have like specific technician working on the MRI, and you say that you are already 2 radiologists now working on that. So if you can just explain more about.
So we don't have just one radiographer. We have many, basically all the radiographers that started fetal MRI in general, they moved to doing fetal cardiac MRI as well, because they're the same ones doing pediatric cardiac MRI. So it's like advanced, let's just say, techniques that not all radiographers do, but the ones that do, they do both. So they have a little bit of experience of both. So they could, let's just say, easily learn to do both. And then, there's always 2 radiologists, because we mainly look at the cardiovascular part, and the other radiologist has an overall look, has a lot of experience in fetal imaging, like standard fetal imaging. So we kind of help each other and compare what we see and what we find to give like one final report. That's pretty much it.
Okay, great.
That's great. Thank you
for commenting on that. So I can already hand over to Domenico now, who is our 3rd speaker. He will talk and introduce our new training platform on our website, of course, as this is the topic of this session. Thank you, Domenico. I hand over to you.
Okay, perfect. So hi everyone. Thanks, Leo. And now as which like in the speaker mode, and let's say that my title, it's like fetal CMR new training concept. And so why are we introducing our new training platform? So because it's something published since last weeks on our website. And why we are doing that? Because also as Davide was saying before, our customer come from different backgrounds. So someone has a fetal MRI experience, someone has a just cardiac MRI experience, or someone really new to both. And we create this platform to accelerate the learning curve by providing structured guidance on device usability, workflow, best practice, and expert recommendation before live training and before first clinical cases. So we just try to change a little bit what is the onboarding for our customer. And our goal is to provide the right support before the first clinical case of volunteer for successful fetal cardiac MRI implementation. So, and the journey is a bit go through the device usability, having a structured learning, having an idea of what is like really exactly the fetal CMR workflow used, and then having expert tips and recommendation, and after that also having clinical technical confidence. So again, why we're introducing that? Because it's built from customer feedback, expert experience. We always try to get some feedback from the customer, understanding what are the issue. It can be the issue related to device usability, patient positioning, and also acquisition. And this training is self-placed before the device installation. It's guidance before live onboarding session, and access to best practice of workflow recommendation. It's faster and more confident clinical adoption, so the people can just do self-learning on our webpage. And providing the right knowledge. I like these sentences, that provided the right knowledge at the right time, helps clinician and right technology start with confidence and achieve successful clinical implementation from the very first cases. And here, so it's our, I just apply here our PDF for our customer onboarding pathway. So this is the PDF that also we send with our SmartSync box when we just ship the device to a new customer. And here it's like just show the entire onboarding steps for fetal cardiac MRI, and the journey comprehending like basic training, basic application training that the people, a clinician and technician, can do easily remotely online through our webpage, and then the advanced step with advanced application training and image quality enhancement, and also explaining a little bit more what each steps includes. Here is just a video that show a bit the platform walkthrough. So, and in this case, we'll just run the video because I think will be really easy for everyone understanding how it works. And in this case, you can see that, of course, you need to do the login. So, and in this case, of course, like there is my email and my password, and going through. So then you can click on customer support. And after that, you are in your page, in your profile, and here you can find all the information related trainings, instruction for use, advisory notes. And here we're talking about training, so we click on that and we enter in our North Medical Academy. So, and of course, in this case, we are talking about fetal CMR, and this journey comprehends self-training and remote session via Teams. So clicking on Fetal SmartSync, we start our training. It's 3 hours and comprehending 2 self-training modules. And how to prepare, it's always important to nominate the key user. So from the team, so for example, MRI technologists in charge for the application. And here we have how to start the training modules. So we have our basic training, basic application training, and advanced module. And here, scrolling, we have the different modules in details with all the topics and objectives. So we have the basic application training then, so with all the explanation, and then we go on the module 3 and module 4 that are like the more advanced application training, where it's remotely via Teams, and where you can book your session with our application specialist. So with me, basically. And then, of course, we have other additional information. We have this beautiful video that represents the workflow in fetal CMR from Children's Hospital, Colorado. You can download our fetal CMR guide, and then this beautiful remote scan with the University of Bonn. So there is a lot of material, and we put everything together in order that all the people has all the information to start. Starting the training, of course, we have the different section module with the table of contents, and you can also individually select what you really need if you are already experienced on that. This is the module 2, and it's the basic application. Of course, we click in, and then we can just complete the second module. And going to the next step, we have, of course, module 3, where we have to organize our training via Microsoft teams. And of course, the last step, it's a module 4, it's just to book another training where I will be present during your remote session. This is a bit our journey and what we have done in the last period, because we think that really can be helpful in improving the learning curve of the people. And now going more in details about the platform, walkthrough, we go more in details of in what really means going in the module 3 and then attend the advanced application training, because as we say, we have this part on our web page where everyone can do their self-placed training, can complete the training before our live remote session. And here is just the module 3 represent the training that I will do with the customer directly. And in this case, we prepared all this setup to be more focused in this section on the Fetal CMR application protocols, and then how to set up sequences and go through the common artifacts, and then giving also tips and tricks for challenges cases. And regarding the module 4, so in this case, we call it the image quality enhancement. In this case, what usually I do with the customer, I book another session via Teams where I can participate during their first volunteer or patient. And in that case, I can support the customer, also providing exam card vendor specific and helping them during the troubleshooting. That means troubleshooting related to device usability, device setting, position of the transducer, and also how to improve the image quality or solve some problem with image quality. And in this case, everything is done via Microsoft Teams. So my work is always like just to discuss with the clinician, to talk with the team, and to create this really moment where we can share also the problematic condition, try to solve the situation to obtain good results. But in this case, we always questioning, what we can always improve for giving the best experience to the customer. And from this side, we create this new training platform online, but we also, now in this slide, we also thought that also creating a collaboration in this case. We have done a collaboration with the roclub company, and in this case, just bringing my remote support to another level, where exactly we provide advanced remote access. And in this case, this is an optional support. It's a teleoperation, remote support, and then the team from roclub, they will explain more in details. And in this case, there are different benefits. For example, real-time support during your fetal CMR scan. And then, of course, like remote support for the MRI technologies, and also remote education, so interacting and learning. And in this case, of course, review cases, set up sequences directly from my side. And so helping our customer that, of course, are worldwide. And that's it. And now I will directly, I will say that in this case, we can go through the team of roclub.
Yes, exactly. Thank you very much, Domenico. I'm just sharing this slide once more. Of course, also the training application is accessible for everyone. Even if you're not yet a customer, you can just create your account and click through the first videos. And now I'm very happy to introduce Priya and Philip from roclub, who will, as Domenico said, show the roclub solution as we are trying to advance the remote support and how it would really look like if you get that support really face-to-face from Domenico, and how we can help you then best. Thank you, Priya.
Thank you very much, Leah and Domenico, for the introduction and also for the opportunity to showcase a little bit our solution and our teleoperation platform. I'm going to share my screen quickly, so just let me know if you do see them.
Yes.
Yes, perfect.
Perfect. All right. So some very high level information on exactly what is our platform. So our platform is a teleoperation platform, and it allows remote access to medtech equipment. So these are anything from MRI to CT to other imaging modality acquisition monitors and systems. And in a way, this, like Domenico mentioned that it's an excellent enabler for the remote application support for your fetal cardiac MRI scans. So the platform itself consists of three major components. Very quickly, it's the device itself. So this is the roclub device, and this is what makes the magic happen. This device acts as an interface between your medical interface, so your MRI scanner, and our roclub cloud, the infrastructure cloud. It facilitates all the transmission of the data and the commands between your medical device and the remote expert. And more importantly is that this device is connected to the internet, and all updates is done via the air, right? So you don't need anyone on site to do any maintenance on the device. The device is connected to our roclub cloud, which hosts our infrastructure. So this is responsible for the data processing, the storage, and the real-time communication. And it facilitates secure connections between the medtech device, so your scanner, and the cloud and your front end of the app. So there's constant cloud security taking place in the background, right, with end-to-end encryption happening with all data streams. The front aspect of the app, which would be something that you and Domenico and the rest of the North medical team would be involved in, is the roclub app itself. So this is the front-end user interface that your remote expert would be able to log on and then have access to the examination that you are currently taking place or conducting. I am now going to quickly mute myself on the PC and unmute myself on the phone, because I want to show you what it looks like in a real environment, well, in my simulated hospital environment in that sense, right? So just give me one. All right, do you hear me?
Great.
Yes, we can hear you.
I'm going to switch my camera on. All right. So this is what the device looks like. So the roclub device or the roclub connector, it is a touchscreen device. So all of your operations that your radiographer or your specialist on site will need to engage with will be done via this screen. This device is connected to your medical system. So please use your imagination now and think that this is your MRI monitor that you are seeing, and this is your MRI scan that you have available. So the video stream is connected to the connector, and the connector has the addition of a teleconference speaker. So this allows the audio communication to take place with the radiographer on site and with your application specialist remotely. And then it has your webcam. So the solution can support up to 3 webcams. We have a webcam for your radiographer or your patient manager. You have a webcam that can be directed towards the console that has your ECG gating in that sense, and also a webcam that will be pointed towards the patient in the MRI room on the MRI table. So in an ideal world, this is what the setup would look. So it'll take very minimal desk space next to your MRI desk. And all of this equipment that you see here comes part of the package with the roclub solution on that end, right? So this is everything that will be next to your MRI scanner where you are performing the examination. Going to switch back now to back here now. Sorry.
Don't worry.
Audio off or the audio off, all these technologies. All right. So then what would Domenico and his team do when they are providing application support for you? They would log on to the roclub app, and they would have access via the app in a browser. So as I mentioned, it is a browser-based application. The first step is for Domenico to start the session as the remote operator. So you would select start session, select your role as the remote operator, and then start the session. Starting the session will take you into a hardware setup where we would then sit a little bit first in the waiting room. So the person on site will always have to give the remote expert access to the scanner, right? So your radiographer will always have control on who can access your scanner and patient information at any given time. So going back to my setup at the department, this is the message that will pop up for your remote operator. It will say that there is a remote operator in the waiting room, and then your radiographer has the opportunity of joining and accepting all participants. And then from there, we go back to the screen, and your application specialist or your remote expert will quickly just need to make sure that their hardware is set up in terms of they have a microphone, they have speakers, and their camera is enabled and on, and then they would join the call. This would now pretty much put your radiographer and your application specialist in a video conference mode. So very similar to what we are doing now with the webinar and in Teams, just allows the video conferencing to take place so they can already communicate with each other. They can already discuss parameters. They can already discuss indications and where they are with the examination or even before the examination. Your remote expert will then connect to the scanner by clicking to the connect button. And now they will have full access to that scanner and to that patient. Yes, this is the website with the video that Domenico had shown earlier, but I need you to also, once again, use your imagination. But this is me moving my mouse as well. So he will have the exact same features and functions to support you during your examination in this specialty. At any given time, he can speak to the radiographer on site. So we have the speaker and the microphone functions, and the audio can happen. But also there's chat functionalities, right? So if audio is not going to be something, or if you have too much or too many people in the room, you can always go ahead and have a quick chat with each other via the connection. So this is what makes our connection or our platform unique, is that one, there's least amount of equipment that's involved. Two, it allows for clinical advantages like this for remote application support at any time, anywhere, whenever you need it on demand. And more importantly, it also allows for guests to join. So if you're using this for clinical education, you can have numerous guests join the session as well. And my colleague Philip is going to demonstrate this now as well. So he's going to join on his side as a guest to the exact same session. So he's going to choose join the session, and he's going to choose guest as the role. And once again, he's going to go into a waiting room. So remember what I said, only the radiographer on site has the permission to allow or deny anyone from joining the session and accessing the examination and the information. Okay, so he's in the waiting room, and then on my side, there's a message once again on the connector that there is a participant that's wanting to join. So the radiographer will say accept. Now we are in a video conference mode. So your radiographer can communicate with your application specialist. She or he can communicate also with other guests that's wanting to join and learn as well. Philip can go ahead on that side. And then on this end, Philip would connect once again to the scanner. and he will also be able to see the scanner and the examination take place. At this point, Philip is only having viewing rights, so he will not be able to take control of the mouse or keyboard or manipulate anything on the scanner itself. So it's just on a pure viewing right. However, if he wanted to, or if you wanted Philip to be a guest that provides more hands-on consulting or education, he can always request for control, and your remote operator would be the person that would grant it. So this is now my screen as the remote operator. There's a pop-up message that says Philip would like control of the scanner, and I would go ahead and just accept it. And now Philip should have control. So now Philip is moving the mouse and not me as a guest. So your guest has the right to view, or they have the right to have control as well.
Great. Thanks so much.
Thank you.
This is really great also because, so like medical imaging and in general now we are evolving AI and everything. And I think also the remote access is something that it's really something really actual, and it's really important because so how also like we can support best the people, but also how can more people can attend the session, also has a demo session, because we know that it's an application that it's worldwide, and then in this case we can also attend some remote session from US to Europe, for example, and that it's really helpful for also beginner customer, and also within the hospital, it's something that also radiologists can also request the access also, and participating when it's not there present. So thank you so much, and really happy of this collaboration, and hopefully can help always supporting the.
Yes, thank you very much for this practical insight. So we are almost through. Before we finish the session, and also if you have questions, just put them in the chat now. I hope you can see the slides. Yeah. I wanted to announce something very special, because Dr. Malenka Bissell from University of Leeds has just finalized the date of the upcoming fetal cardiac MRI workshop in 2027. So we have around 1 year to go for this very exciting workshop. So it's really dedicated to fetal CMR, what Paola also showed in her presentation. It's a great place to meet with people. Also, if you're completely new, you don't have to bring all the expertise already with you. It will be, as I said, end of June in a really nice location, Hazelwood Castle. So it's 2 days. So if you're interested, just please scan this QR code to take this unique opportunity already now, because the place is of course also limited, or write an email to us. So yeah, this is a really great opportunity that happens every 2 years. Then I would also like to thank for the support from the Fetal Heart Society and Society for Cardiovascular Magnetic Resonance for also sharing this webinar today. And here as a last slide, because of course, after the webinar is before the webinar, we have already scheduled our next session this autumn in September 16th. Just scan the QR code now, so that you're already registered for the next one and that you're not missing out. Of course, topics will be announced soon in a couple of weeks. And then I would like to thank you all for your attendance. And now we are very happy to answer questions. You can raise your hand, you can speak, or just put them in the chat. Thank you.
Thank you.
So let's see, do we have any questions? I don't think here at the moment. Let's see, do I have something in the chat? Not for the moment. Maybe in the meantime, Paola and Davide, if you would need to break it down very shortly, what would you suggest a person or a site who would like to start with fetal CMR? They're completely new to the field.
Good question.
Yeah.
So if I can go first, well, as I said during my presentation, I mean, for me, it was really helpful to visit Malenka and David, because there I was able to see actually what an already running program is like. So for sure, if you have the opportunity, my advice is to try to visit an experience center. And then obviously all the training process is really important, not only for the device, but also to start acquiring sequences, like from also your sample exam cards according to your scanner, so according to the field, but also the producer, and then obviously practice and try to optimize every session a little bit more your sequences.
Yep.
Okay.
Yeah, it's true. Also because in this, like, we are really happy also to connect with other experienced customer, and also happy to organize also visit on site. Yep. Davide.
Yeah.
So I think no.
Yeah.
Sorry.
If you would like to say something.
No, I agree with Paola. I mean, this is one of the fields where you need to see things and before you actually get to do it on your own. You need to go somewhere. You need to, of course, you can start by studying articles and read, but then again, you need like real life because otherwise you really get like discouraged at the beginning because you don't really get nice pictures and it can be quite frustrating. Sometimes it's frustrating even now because when the fetus moves a lot, it's difficult to get diagnostic images. But over time, you learn that by doing it over and over again, by getting external support, by going to places where there are, more experienced people that can help you troubleshoot your problems. It's a learning curve that's not very swift, but if you wanna, get your hands on this application, you need to start with the people that know how to do it. So you can't really do it on your own.
Yes.
Yep.
Yeah.
That's true.
Of course, we can only agree on that. That's why we're always trying to push conferences or workshops and also like the educational platform. I think we have 2 questions.
Yeah, I think there is one question from Gil, and are the tools and application for analyzing scene sequences specific to the MRI equipment vendors or from another provider? I think, Davide, you show like Q-flow images and also calculation of ejection fraction for the scene images. And I think, so what you can say about that, but yeah.
They're not specific to fetal cardiac MRI. We use the software that you use for standard cardiac MRI applications. So of course it's more challenging than cardiac MRI images, but you don't need a specific thing for that.
So there is no change in your cardiac workflow, let's say.
Yes. Then we have another question. Can the speakers share their experience about the choice of coils? Body 18 coils are bigger in size and scanning small fetal heart would not be ideal.
I think, for example, yeah, so like Davide, please, if you were talking, right? Or
No, sorry, go ahead if you want to.
Yep. So I think in this case, like Davide, you have like Siemens scanner, right? And then Paola, you are more experienced on 3T Philips scanner. So I would say that just here we have and then the first approach, like some differences in coil, where also the Philips you're using also a bigger coil, and maybe Paolo, your experience about that? No, because I think, like, I don't know if you have any.
Yeah. I use actually the big one, anterior coil, and then the posterior coil built in the scanner for a total of 32 channels. And actually the anterior coil is a little bit big, obviously. So that's why we try to use all supports and pillows to make less uncomfortable for the mom having this big coil on her tummy, and obviously it's important to try not to avoid the contact between the coil and the probe of the device. But yeah, I know, for example, that there are some centers that are lucky enough to be able to use lighter coils and also lighter coils, but we are still using that one. And I mean, we are managing to use that, and moms don't complain so much. But obviously, if you are able to use lighter coils, probably it's better.
Yep.
Okay, thank you, Paola, for that comment.
You also need to make do with the coils that you have.
Yeah. That's true.
Yeah, it's
So
true.
it's we would all like to have like the best coil for the exam, but it's not always possible.
Yeah, that's true.
Yeah.
So we have last two quick questions. First, how long does one fetal CMR take? Wondering about fetal movements. And the second, what earliest pregnancy weeks preferred for doing fetal CMR?
Yeah. So if I can go first, as Davide said, for one fetal CMR, we consider like 45 minutes, maximum 1 hour. Obviously, it depends on the fetal collaboration and fetal movements, and if the mom is able to stay in the scanner for such a long time. We always tell moms at the beginning of the scan that obviously we see them and we can talk to them, we hear them all over the scan, and they can tell if they want to stop earlier. But then, that's the medium duration.
Thank you. Yeah, and then we have what earliest pregnancy weeks preferred for doing fetal CMR?
I would say that it's very, very difficult to do it before 30 weeks because the fetus will move a lot. The heart is not big enough. So if you can wait until the fetus is at least 30 weeks, I think the third trimester is the best time, because the fetus would be in position, it would move less, the heart would be big enough to be studied. Otherwise, it becomes a nightmare. We tried, but it's very difficult to do it before 30 weeks. I mean, at least in our experience.
Yeah, that's what we also recommend, right?
Agree for that.
Gestation week 30. So I think that's it for the moment. We're already a little bit over time, but again, thank you very much who joined until now. Thank you, of course, to all of the speakers. Very grateful for your input. I think it was another very great and relevant session. And as I said in the beginning, we will share the recording for you, which you then are also free to share with colleagues or everyone who is interested. And with that, I wish you a good day, good night, good morning, wherever you are. And see you next time in autumn. Thank you.
Thank you so much. Thank you,
Bye.
Davide. Thank you, Paola, and roclub team.
Thank you. Bye.
Bye-bye.
Bye. Bye-bye.